Thank you. Good morning. As you can imagine, it is a hectic week. Thank you for being here, and I also want to give a shout out to Senator Tony Atkins, who's also wrapped up. If you can imagine, we have other bills we're working, but I wanted to be here to thank you all. I want to thank Roseanne again, our fabulous executive director for the National Nurses United and California Nurses Association, for Robert Poland, our distinguished professor in economics and co-director of the Political Economy Research Institute of University of Massachusetts, Amherst. And people are often asking us, why did we select Mr. Poland? But what you may or may not know is that he actually was one of the economic advisors for Governor Brown when he ran for president, and are friends with the governor. So, we're making sure that we solicit people that are close to the governor, that are friends, and that trust him and trust his guidance. So we want to make sure that we also get it right. We know he's a national expert and economist, and so we're very proud to have him here as well. Today we are introducing the economic analysis of Senate Bill 562, and here are the facts. Californians already pay a lot for health care. Nearly 14% of our state's gross domestic product goes to health care, and that amount will keep rising unless we do something. As many as 1/3 of Californians are uninsured, meaning they pay huge costs and healthcare premiums and out-of-pocket expenses as well. Young people aged 21 to 39, just excluded me by 3 years, man, so I'm no longer young, are the largest group of uninsured. That is when people are starting families, when people are starting jobs and buying their first homes. Without a secure health care, we are limiting their futures. Now we know, and we've heard time and time again, the uncertainty of Washington and this president's continued attacks on the Affordable Care Act. Now Republicans in Congress want to take that health care away from 23 million people and raise the cost of health care for many Americans. That is simply the fact, and you can see what is happening in D.C., especially for our older Americans and those with current health conditions. We are on a collision course for rising health care costs and a crisis for California's middle class. The good news is that California can get a lot more for our money. When the legislature passes the Healthy California Act, we will actually spend less than we do on health care. Families will pay less for health care. The average middle-class family will see their out-of-pocket costs fall by 9%. And if they now buy insurance, and 2.6 if they can get insurance from their employer. So businesses will also pay far less. Small businesses with fewer than 9 employees will provide health care. We'll see costs fall by 22%. Middle-sized businesses with 10 to 19 employees will pay 13% less than they are paying now. Even large businesses with 500 employees will pay less. Healthy California cuts the cost through better administration and lower prescription drug prices. Having one public-run system will reduce inefficiencies and missed prevention opportunities the way we do with Medicare now. Californians will get more and will definitely pay less. Comprehensive health care, including dental and mental care coverage, the freedom to choose your doctor instead of a narrow network of limits. The economic analysis proposes several ways to pay for universal health care here in California. The legislature will be looking at all these proposals as we move forward, and you will hear more about them today. I want to just thank everybody for being here, and again, thank CNA for entering with me into this big fight. We know this is not easy. We are also going to now begin our stakeholder process and engage our different stakeholders to ensure that now that we have a finance plan, that we can look at it, study it, address it, tweak it, so that we move forward as a united front to ensure that we finally get to a place where we reach to a universal healthcare plan here in California and combat what is actually happening in D.C., where they continue to attack healthcare like we've never seen before. So this gives California an opportunity to once again lead. I look forward to joining arm in arm with CNA as we move forward and with my joint author, Senator Atkins, to make this a reality in California. Thank you.
Thank you so much, Senator Lara. Just how bold you are. And thank you really on behalf of, I know the nurses really want to thank you on behalf of all of their patients. It's like a heartfelt, yeah. Thank you. So obviously, I have the pleasure of introducing Professor Robert Poland, someone I have enormous respect for. I mean, just enormous respect, because not only he just cares about the human condition, and he uses all of his time, his free time actually too, to actually help in any way possible across the spectrum. And he's been an ally of working people. He's been an ally of struggling people. He's been an ally of people who have been desperate in their own lives in need of health care and employment and just about everything. He is, as I said, from the University of California. He worked at the University of, he was a professor at the University, I'm going to get this right. He was a professor at the University of California, Riverside for 16 years. Is that right? And he heads up the Perry Institute at the University of Massachusetts. But beyond that, he works on, he actually uses his knowledge and his resources to help wherever he can. And he'll tell you about the study. What is just amazing is just to consider the fact that this ends up as such a cost savings for California, and this bill will be the model for the nation. So I am just extremely happy to introduce Professor Robert Poland.
Thank you. I'm very happy to be here. It's true, I was at UC Riverside for 16 years, so I am pretty much a Californian. I raised both of my children in Riverside. Why did I leave Riverside? Well, as Roseanne said, I'm the co-director of the Political Economy Research Institute at University of Massachusetts, so that was an offer I couldn't refuse when it was made to me, so we moved to Massachusetts. But I am happy to have been given the opportunity to work on this bill, and I want to just give you the main features. It's a big, complicated analysis. There's all kinds of computations. I think 99.7% of them are all entirely right. There may be a few things that are tiny that are wrong. That always happens. But here are the basics. And I'm going to kind of read over it to make sure I'm getting the numbers right, the basics. Okay, so there's four basic components to the study. There's four sections. First is we look at the cost estimate for the healthcare system at present and bringing full coverage to everybody in California under the existing healthcare system. That's step one. Step two, we then consider where we can get cost savings through the Healthy California bill. That's step two. Step three is we then consider how we finance Healthy California, because obviously we're not going to be financing the way we finance now. And then fourth and finally, we look at the impact of Healthy California on the financial situation for individuals and businesses at all levels. And those are the numbers that you see right here. So let me just go through in all four of those sections, the basics, and then we'll open for discussion. Right now, the healthcare system in California, the total level of expenditures is $368.5 billion, so roughly $370 billion. So I know that you've heard these reports about the study that came out last week by the staff saying that this would cost $400 billion, this measure. Well, keep in mind, we are already spending $370 billion. We're not going from 0 to $400 billion. Okay, that's step one. Now, under our present system that costs $370 billion, thereabouts, 33.5 million people are insured and 2.7 million are uninsured. Now, among the 33.5 million who are insured, about 36% or 12 million are underinsured. And what we mean by underinsured, as Senator Lara just said, these are people that have insurance, but their deductibles, co-pays are so high that they're discouraged from actually using the healthcare system. Okay, now, so the first step in our analysis is therefore to ask, what would it take to bring the uninsured and the underinsured up to full insurance. How much would that cost? And the answer is it would add about 9.6% to total costs. So the system that now costs roughly $370 billion would cost $400 billion, or actually slightly more, if everybody was fully insured under the existing system. So actually my result, and I shouldn't just say my, because I have some fantastic co-authors, James Heinz, Peter Arno, and Jeanette Wicks-Lim. So our analysis is basically on track with that of the staff report in saying that if we were going to operate our present system, giving everybody full coverage, it would cost $400 billion. That would represent an increase from 370 to 400, not from 0 to 400, a critical point. Okay, now, second, this single-payer system, as Senator Lara just said, has built-in features that will generate cost savings. And what are they? Okay, so we consider two broad areas. One is what we will call structural changes, and the secondly, we talk about efficiencies in service provision. And in developing our estimates, we build exclusively from the research literature. If you look at the study, there are 6 full pages of references only, and it's in a small font, 10-point font. So there's a lot of references. This is from the professional literature. Okay, so what are we talking about? Number one, structural changes. We're talking about reducing administrative costs across the board. By having a single-payer system, you will save on administration for hospitals, for physicians, for clinics, and in insurance itself. Secondly, we're talking about lowering pharmaceutical prices. And by that, we're looking at both the VA-type model for setting pharmaceutical prices and the Canadian model. And so we think through some combination of something like that, we can reduce pharmaceutical costs in the range of 30%. Third, service provision, we suggest setting all service provision at Medicare rates, okay? So right now we have 3 tiers. We have Medicare rates, we have private insurance rates, and we have Medi-Cal rates. Medi-Cal rates are lower than Medicare rates. Private insurance are higher. We're saying move everything to Medicare rates. So if you combine those 3 things, conservatively we estimate that you can get 13% savings out of what we do with our present system. 13% savings through administrative efficiency, pharmaceutical prices lower, and through setting rates according to the Medicare rates. Now, on top of that, we also look at inefficiency or waste in service provision. And here, we're drawing primarily on this massive study that came out in 2010 from the U.S. Institute of Medicine, which is the medical research branch of the National Science Foundation. Now, what they said in these areas of service provision, which includes unnecessary services, inefficiently delivered services, misprevention opportunities, and fraud. So those 4 sub-areas: unnecessary services, inefficiently delivered services, misprevention opportunities, and fraud. They said as a lower bound estimate, we are wasting about 19% of all expenditure, okay? Now what we're assuming, quite conservatively, we're assuming we can only get 5% out of that 19%. I would like to be able to say we could get the whole 19%, but we're gonna be very conservative, and we're gonna say we only get 5% of the 19%. So you add up our 2 sources of savings. The structural savings is 13%. The savings in service provision, 5%. That gets us to 18% savings. Okay. So remember, we said, yes, it would cost $400 billion to cover everybody in California today under the existing system. when we then extract 18% of savings from the system, the overall costs go from roughly 400 to roughly 330 billion. Okay? So the system will cost 330 billion. Again, we're not going from 0 to 330 billion. We're going from one that is costing now 370, and it's going to go down to 330, plus everybody gets covered. Okay? That's it. Now, how do we pay for that 330 billion? Obviously, it's a completely restructured system. Right now, public sources of funding cover roughly 70% of all funding in the system, okay? So that 70%, if we're talking about the 330 billion, we're saying that the public sources of funds, including Medicare, Medi-Cal, and other public sources, will still cover. Okay? In fact, it is mandated that it continues to cover under the Affordable Care Act waiver, which gives the provision for states to develop their own health care systems and still receive all the funding, the public funding that they're receiving right now. Okay? So we're assuming that that 70% is still going to be there. That 70% amounts to 225 billion. Okay? So we have a system that's going to cost 331 billion. 225 by law will come from existing public sources. That means that we need to find revenue for 106 billion extra. Okay? Where do we get the 106 billion extra? Well, as Senator Lara said, there's various ways to think about it. We propose one basic way, and then we have an alternative. But let me just give you the basic. The basic way we propose is through two new taxes. A gross receipts tax at 2.3% of gross receipts, and a sales tax increase also at 2.3% of sales. Now, both of those have exemptions and a tax credit in them to maintain equity in the system. And with respect to the gross receipts tax, we propose that businesses that have gross receipts, let's just say the first $2 million of all gross receipts for all businesses are exempt from the tax. Now, the effect of that is that basically small businesses will pay no gross receipts tax. The average level of gross receipts for a small business now is less than $1 million. So nobody pays anything until you hit 2 million. And then you just start paying on the first dollar after 2 million. Okay, so that's the way that we get equity in. And so including, therefore, the businesses that are not paying for health care now, small businesses will still not pay anything for health care through the tax. So with respect to the sales tax, we exempt necessities, food, housing, utilities, and a range of services consistent with the service exemptions that exist now. Plus, for low-income Medicaid eligible families now, we propose a 2% tax credit so that the people who are getting Medicaid now, support through Medicaid, will effectively not have to pay the sales tax. Their costs will be zero. So that's it. Now, what is the impact of that? How does it all work? So the two taxes. The gross receipts tax, as I described it, raises 92.6 billion, and the sales tax generates 14.3 billion. We end up with 106.9 billion in total. I think it works really well. It's tight. Now, the results for businesses and households are here. So why don't we just talk about them a little bit? Well, I guess I need to stand at the mic. Okay.
You can move it. It can move.
Yeah? Okay, well, anyway, it's right out of my paper, so I'll just read it from the paper. Okay, here's what it looks like. Same thing. So, with the new taxes and with the exemptions and yeah. So this one is households, and this one is business. This is right from the paper. Okay, so here's what we find. Low-income families that are on Medi-Cal now are going to see their healthcare costs go down by 5.5%. Now, wait a minute. How can you say they're going down if they're on Medi-Cal? Because they are paying out of pocket now. They are paying out of pocket. And nobody is going to pay out of pocket anymore. Okay? Now, if you are, this is a 35,800 family, which is basically the second tier. If we divide the entire income distribution of California into 5 tiers, this is the second tier. They will see their health care costs go down on average by 1.2%. Now, so what we're doing, we're looking at how much they're paying now in health care, and we're matching that against a family. They're going to have to pay sales tax for non-necessities. Now, middle-income families, this is basically a windfall for middle-income families because they're paying a lot for health care now. So the range is for families that are underinsured now, the net gain is 8.7% of their income. For individually insured families, the gain is 9.1%. And for those that are getting health care, middle-income families that are getting health care from their employer, it's somewhat more modest, but still, it's a gain of 2.6%. Now, it is true that wealthy households will pay more. So these are in the top 20%, families at an average income of $227,000, and top 10% at $340,000. They will go up. But look at what they're doing. Right now, the wealthy families are getting a net subsidy. Yeah? They're getting a net subsidy because of the tax benefits. They're able to write off their health care costs. So they are getting 1% of their income is getting paid to them by the health care system. Under the new, under Healthy California, well, yes, they will pay, but look, they're only going to have to pay 0.6% of their net income. So they're going to go from a situation at present in which they were paying, they're getting a net subsidy of 1% to one in which they have to pay 0.6%. Now, finally, what about businesses? Now, so businesses are going to have to pay the gross receipts tax after the first $2 million of expenditure. Okay, so what do we see? Small businesses. Well, the small businesses that are not covering their workers, they still won't have to pay anything. They will be exempt from the gross receipts tax because their gross receipts are under $2 million. The businesses that are small and that are paying health care for their employees now, also a huge windfall. Their health care expenditures are going to go down by 22% as a share of their payroll. So this is a huge benefit for these small businesses. Similarly, middle-sized businesses. We're looking at 10 to 19 employees, 20 to 99. We have net benefit relative to payroll. Their net spending relative to payroll goes down by 13.4%, 6.8%. Even large businesses now. So large businesses up to 500 employees, net increase, net reduction in spending on healthcare relative to what they're spending now is 5.7% of their payroll. This is for big businesses. And then the very big, plus 500 employees, we see that they're, even those, they will, of course, have to pay a large chunk of gross receipts because they have a lot of gross receipts. But nevertheless, their costs will also go down, we estimate, by, on average, 0.6%. So businesses at all levels come out at least as well. Most of them in the middle come out much better. This measure is good for business. First and foremost, this is really good for business. It's also good for households. We see the results. So that's basically what we found.
So I'm going to assume you have some questions, but I thought you did a brilliant job there in terms of demystifying the healthcare system, because I think the numbers get, when people, I'm going to ask Michael Leidy. I'm here. Whoa. See, ask and you shall receive. Okay, so,
Can I just say one thing, Roseanne? I just wanted to,
Yes.
highlight this chart on the right.
sure. Michael, why don't you highlight this chart on the right? And then we'll take questions and provide answers, and then continue the discussion as we will. So, yeah. So Bob, you want to come back, and Michael? You
So
wanna-
I just, Michael Leidy, Lighty. This is a poll that we were, that was in the field Thursday, starting Thursday. So it's a very recent survey of public opinion. We even used the argument that said, oh, this is going to cost $400 billion. And you can see, despite that, 58%, even with that argument, supported SB 562. But look at the total support, 70%. 94% for lowering healthcare costs, 93% for lowering prescription drug costs, 92% allowing patients to choose their own doctors and healthcare providers. Elimination of premiums, copays, and deductibles and out-of-pocket expenses, 82% support. This kind of support ensure that every Californian has healthcare. 81% of Californians want us to do that. This Healthy California Act does it. In addition, we show how we pay for it. I'm trying to figure out what's the argument against it, Bob.
So, should we go to questions? Yeah. Bob, do you want to take that mic?
Sure,
and-
sure, sure.
So, question. Anyone have a question?
Yeah, sure.
Okay,
If you could say who you are and where you're from.
hi, I'm Victoria Collins, I'm with Politico. I know you do mention Kaiser in the study, and it's a big force in California. You also say that that's basically the model would, doesn't mean the model will be appropriate for the future. So can you talk about that? It's 25 to 1/3 of.
25%, yeah. Well, so, the way that we were thinking about Kaiser is a lot of the evidence that we have on the potential for cost savings, for example, from the Institute for Medicine study, saying there's a 19% potential savings, lower bound. We assume that number is going to be somewhat lower in California because Kaiser is covering 25% of the population, and because Kaiser is operating at a relatively high level of efficiency vis-a-vis the rest of the system. So that's basically what we meant with respect to Kaiser. Now, beyond that, the basic feature of the bill talks about ways through which, it's a general theme on integrating care and achieving efficiencies. We're not saying that the Kaiser model is the model by any means. We're just saying that integrated care is going to result inevitably. Obviously, if we're systematizing costs across the board and we're increasing transparency across the board, it is going to yield efficiencies.
Does this do away with that model? Does it allow it to continue as, or, other HMOs, this is the land of HMOs, what California's been based on. I understand that this changes that dramatically, but how?
You want to?
It does not eliminate Kaiser. And in fact, it doesn't presume that we're going to have one type of model for care. There's a combination, as Bob said, there's a combination of Medicare rates on the fee-for-service side, and there's also a provision for capitated payments to integrated healthcare organizations. So it is literally a mixed payment methodology system. Well, what the difference is that the Kaiser Health Plan will not be driving the decisions, but rather Kaiser nurses and doctors will be in charge.
Okay, so it allows for a fee-for-service and capitated model
Yes.
as well as all that to exist.
That's right. And this is an important point, Victoria, because the Senate Appropriations analysis was wrong on this point, that they presumed it's an entirely fee-for-service system. It is not. And what we did was, as we said we were going to do, we were going to let the financial analysis drive the policy decision on payment methodology, and we have now done that.
Laurel Rosenhall with Cal Matters. This question also for the authors of the bill, but maybe the nurses could speak to it since you're the sponsor. So the funding mechanism you lay out here with the gross receipts tax, the sales tax, the use of the existing funds for public insurance programs, is that the funding mechanism that's going to be proposed in SB 562?
Well, what Senator Lara said was he was going to engage in a stakeholder process and a process with legislators to come up with the actual language in the bill. This is the proposal that the sponsors are urging adoption of. We also have an alternative funding mechanism based on a payroll tax. It is substantially less than the payroll tax that was in the appropriations analysis. Again, that was speculative. This is real. And so I think Senator Lara has reserved the right right now to make a final decision on that.
So when would we see what the actual funding mechanism would be in the bill itself?
That you definitely want to talk to Senator Lara about that. It has not yet been scheduled. It's obviously eligible for a floor vote now, and so we're looking forward to passing it this week.
So this week?
That's what we're looking forward to. Yes.
So for Lara with the AP, it seems like potentially people who are currently insured now, if they no longer had to pay like deductibles, co-pays, that type of thing, they might actually seek out more healthcare services. Is that something you accounted for in this analysis?
Yes. Okay, so the issue that you're raising is very important, the issue of utilization. And yes, and we do go through the literature in considerable detail on potential increases in utilization. So in our study, so what we are assuming is that the uninsured, the currently uninsured utilization goes up by 50%. The underinsured, we're assuming utilization goes up by 15%. If you actually read the relevant literature, what it says is that the studies find that utilization for underinsured, when people see the deductibles totally go away, the utilization goes up by 10 to 15%. So we took the high-end number on that. We took the 15%. On top of that, part of what makes utilization go up is not that people seek out doctors more, but what we call physician-induced demand. And the incentive, obviously, for physician-induced demand is that they can make more money by requiring more tests and so forth. So what will happen under this system is that the incentives for physician-induced demand or hospital-induced demand will go down. One, because we have the fees fixed, but they still could have a incentive to increase the number of treatments and tests and so forth, even at a fixed price. So what we have also argued for in the proposal are measures to control that, so that within the framework of integrated care, that we would have rate setting or at least rate supervision that would also control that increased quantity. So when you add all that up, then we did look at the literature. When you get rid of the impact of deductibles on the utilization, demand-side utilization, the patient-led utilization, there really isn't, the issue of small copays doesn't seem to affect utilization very much. But we account for that. We say because we have overstated what we expect would be the rise of utilization for the underinsured. We're saying a 15% rise. And because we're saying that this feature of physician-induced demand is also going to be dampened.
I just want to add, Bob, too, I think it's fair to say that we expect California to be healthier, and that through preventive and early intervention, which is now, there are financial barriers to care to access, well, actually, we believe that will have a positive impact, too, on utilization, especially more expensive utilization down the road. So the chronic illnesses like diabetes in this system will be better handled.
Yeah.
Go ahead. Sorry. Yeah, sorry.
Yeah, sit on the left.
Yeah.
Can you talk more about the savings from pharmaceutical savings? How certain it is that those costs, 30% savings is pretty dramatic, and how certain it is that would become a reality?
Okay.
I'm sorry, I didn't hear your name, sorry.
Katie Murphy.
Oh, that's right, yeah, Katie. Hi.
So again, basically we're working from the research literature. And if you study the VA, the US VA system, there's different estimates as to how much they're able to save through their formulary. The estimates range between 40% and 60%. That's what the research says. Now, there is an issue with respect to the VA in that it obviously covers only a segment of the full demographic spectrum, that is adults, and mainly male adults to date. And so one could say, well, okay, that it's easier for them to get that level of saving because they have a more narrow range of coverage. So that's why we also looked at the Canadian system. You know, the population of Canada is roughly the same as California, and the demographic is basically a whole country, like there's a whole state. So in Canada, they're at roughly 30 to 40% savings relative to what we pay in the US. So if you look at the results from both the VA and Canada, I think it's fair to say that that we have 30% savings as a conservative estimate that could be extracted relative to what we're paying now on pharmaceuticals.
Gentleman had a question.
Mike Monaski from Elk Grove News. Could you summarize your methodology, and because these results should be reproducible, and then also how did you incorporate dental and mental health costs?
Yeah, so definitely they're reproducible. In fact, if you look at it, it's pretty simple stuff. I mean, the hard thing was, just gathering the literature. And then it's pretty much arithmetic. And I think if you look at the tables, I show exactly this plus this equals this. So
I think
that's
there's some multiplication in there too.
a little bit, yeah. But we don't want to push too far. I mean, there's no econometrics. I love econometrics personally. I've been teaching it for zillions of years. And if I had more time, I would maybe do some econometric modeling on this stuff, on how, once you get these benefits, what are the spillover effects? But we haven't done that one yet. If the nurses ask me or somebody else, maybe if I have time. Anyway, okay, so that's basically the methodology. It's fully reproducible. It's all publicly available data. There's no secrets at all. And then what was the second question?
How did you incorporate dental and
Oh, yeah. So the dental, as you know, most dental is not covered through Medicare. So basically, though, what we say is that the fee structure for dental will simply replicate the fee structure that exists in Medicare for non-dental. There are some features of dental, acute care that are covered in Medicare. And on this issue of people being healthier. So dental costs should go down to the extent that people are able to get regular checkups who now wait until things are really severe. And then Medicare pays for it. So basically, again, we think it's a conservative estimate to allow that we will, the Medicare rates are basically 22% below private insurance. And so therefore, and they're 15% above Medicaid. So we are going to assume that dental rates moving from private to Medicare equivalent rates will also go down by 22%.
And we cover mental health, I think.
And mental health, yeah.
Thank God. So, no more questions? All right, so we'll be here for a few minutes if you have questions. I want to thank everyone for coming out, and Bob, Professor Pullen will be available. We've gotten to know each other. Yeah, he'll be available for questions, and this is extremely exciting. Michael was effervescing when we came into this room today because ultimately we're saving Californians money, we're making this population of California healthier, and we're setting a model for the nation, and the nation needs good role models at this juncture in history. So thank you, and thank you nurses for your sponsorship of this bill.